I was given the title Esophageal Atresia the first 5 years, which I could probably cover comprehensively in about 5 days, but I've got 20 minutes, so I'm going to try my best, but we'll see how we go on. So the overview of the presentation is to talk a little bit about how they present, a little bit about what I do with the surgery, how in Bristol we manage them, and I don't know if any of you are coming from out of area, but there are differences in different surgical centres, and there isn't an absolute right way to do things. And then a little bit about what happens when you go home with your child. And in the middle of it, Emma is going to chip in and talk to us about the research that she's running, and I'm kind of the chief investigator of. So I've got kids, you read all the books, and unfortunately for esophageal atresia, it comes usually as a shock to most parents. So if you look at VACTERL was a survey that was set up out of Oxford University, and they would pick a congenital anomaly or condition, and then they'd get national data and have a look and see what happened with babies at a national level. And actually, it's the VACTERL data for esophageal atresia is now quite old, but at that time it was about 1 in 5 were picked up or suspected antenatally. If you read research papers, about 50%, so if Emma, who's a fetal medicine trainee and specialist, if she did your scan in pregnancy, she'd have a 50-50 chance of picking up that your baby had esophageal atresia. My children, I didn't have complicated pregnancies, thank goodness. I had a sonographer who was very well trained, but they're not looking at babies with congenital anomalies all the time, and the signs can be really subtle and difficult to miss and difficult to pick up. And so you often have a very normal pregnancy and your baby arrives and you're not in a surgical centre. And I think it's a huge, big shock for families to get over that initially. So I'm just going to let Emma chip in, because as a surgeon, that's frustrating that I don't know what's coming. I'm on call this weekend for esophageal atresia. I'm on tenterhooks because I have no idea what's coming from around the southwest, but I'll let...
Hiya, so my name's Emma. So I'm an obstetrician and gynecologist, but kind of training in fetal medicine, which means that I was nodding away at your description of twins. It was perfect. So I'm kind of I've taken time out of training at the moment to do some research into antenatal diagnoses, mainly of babies who've got anomalies that might require surgery. So actually, I was very lucky. Prior to my research starting, Claire and another colleague had set up already the Surgical Pearl study, which is a big study where we're basically aiming to recruit families with babies diagnosed antenatally, mainly with congenital anomalies that might require surgery once the baby's born. So obviously OA TOF is a kind of component of that, but our large cohort and proportion of our families have got cardiac anomalies or other GI tract anomalies, and some thoracic cases. So what we're doing is collecting triads, so mums, dads and babies, and trying to take samples so that we've got a biobank of studies, of samples that we're able to do further research on. But we're also trying to get demographic data so that we can look into things that are happening. The research that I'm kind of currently working on is looking at, it's not genetics, but looking at different things within mum's blood that might be predisposing those pregnancies to other conditions, so anomalies. And it's just things that we don't really know enough about yet. And the interesting trial kind of pilot data we have is mainly, again, due to babies with cardiac anomalies, but we're hoping to extrapolate it to OA TOF, although, as I'm sure you can see, we have 185 families in the study at the moment, and only 12 of those are OA TOF, which just shows how rare the conditions are that we're seeing. And I can confirm that only a third of those families were antenatally diagnosed. So the rest of those families of OA TOF we picked up once the babies had been born and were brought to Bristol and diagnosed postnatally. But the interesting results that we've got so far is that there is probably a difference in these metabolites, so proteins, fats, other types of molecules in the blood of the mums where their babies have got anomalies. And so we don't know the significance of that just yet. We don't know if it's that the mum has a higher risk of having a baby with a condition, Or has the pregnancy changed the samples within the mum's blood? And so that's what we're really looking into at the moment, part of stuff that we're really looking into at the moment. So if that kind of pans out and we can get much more good information and good data about that kind of test, then it might be that we can provide a screening tool used either pre-pregnancy or in early pregnancy to help us basically offer more vigilant scanning so that you're seen by a fetal medicine consultant rather than only having your anomaly scan. The other part of my research is that we're piloting a new type of brain ultrasound within fetal life to try and gain prognostic information for families. So we're looking at all conditions, all anomalies where the baby might need surgery once they're born, and trying to look at the blood flow within babies' brains, because we, again, don't know if there's a difference between the blood flow in these babies' brains with conditions that might require surgery or normally grown babies in the uterus. And we're not entirely sure whether there's definitely a relationship between difference in neurological outcomes with babies, mainly with cardiac conditions. But we're trying to figure out if there's a way that we could predict that in fetal life as well, so that we can give more information to families. There's a huge amount of information. I don't fully understand it all yet, and I've got 2.5 more years, so that's good. But if anyone has any questions, I'll be with Claire and I'll be here all afternoon as well.
Right, back to the whistle-stop tour of the first 5 years. So most families, the first kind of idea that you have that there might be something not quite right with your baby is that they really struggle to feed. And there's this kind of idea of being a mucousy baby, which is actually they're not able to swallow their own saliva. So it's this kind of bubbling up around their mouth. They may also have difficulty breathing because some of the saliva is trickled into the main airway. And then what will happen, and this happens at any of the hospitals in the southwest, is that one of the midwives on the postnatal ward will come along and try and see if they can get a tube to go down into the stomach. So this is an X-ray that would have happened in the local hospital. And I don't know if I've got a pointer that works. Hang on, let's see. Nope. There we go. So that's a tube, which you can't see either end because they're sort of off the picture. But they've tried to pass it and it's just not getting beyond there. So that's the kind of upper bit of the esophagus and doesn't connect going down into the stomach. So then Bristol, this is a kind of map of, there's been a big reorganisation of paediatric surgical care in England. And we now work in what are called ODNs, or operational delivery networks. So there are 10. This is our patch, the Southwest. Quite unusual that we're the only paediatric surgical centre within the ODN. So lots of the other ODNs, for example, London, have got 6 paediatric surgical centres within London. So we have people coming all the way down from Truro up as far as Gloucester or Cheltenham, all come into Bristol. And listening to what the TOFS charity has said, that you want us to subspecialise. I've been a consultant for just over 4 years now. When I started, all of us were on the esophageal atresia rota, and there are now 4 of us. So there's myself, 2 of the most senior surgeons in the department, Mr. Garrett Cox and Mr. Rogers, and Miss Bradshaw is another one of her colleagues. So you just get one of us looking after you. This is a screenshot to kind of show where we sit compared to other centres. So to interpret this is national hospital episode data, and it covers a 3-year period up until September 2024. And it includes all the patients having esophageal atresia repairs in the UK. So the volume nationally over 3 years was 526. And then the circles that you can see with the dark circle here are each individual centre and how many procedures that we're doing. So above us, the highest volume, I think, is Great Ormond Street. Now, I did some of my training in Great Ormond Street, and they were definitely not busier than Bristol. So I think some of those patients are patients that are coming for particularly difficult long gap esophageal atresia repairs. And then the only other 2 centres are Birmingham and Liverpool that see more babies with the condition. But still, they're tiny numbers, really tiny numbers, 36 in 3 years. So we averaged about 12 to 13 a year. And yes, we've limited the number of surgeons. And we've kind of happened on 4 because of holidays and everything and keeping up kind of the expertise. But it is a really rare condition. and that kind of explains why your GP may never have heard of it. So we touched a little bit on the different types of esophageal atresia. It's important for me because I need to know what I need to do at the time of the operation. The middle one is the really common one where you have this upper pouch that doesn't connect to the lower esophagus and it goes onto the back of the trachea. As Charles said in his presentation, it's intrinsically linked to the whole development of the airway system. So when you have this issue, it's very common that the trachea itself is not normal to begin with. And lots of babies have very severe tracheomalacia that actually, when I first started operating and seeing it, I was like, is there something that I've not done correctly at the time of surgery? But it's a kind of how the whole development has occurred. So that initial x-ray, just to kind of feed back into it, we already know. So if we get the call from Torbay this afternoon that they've got a suspected esophageal atresia, when you look at the x-ray, the fact that you've got these dark, I don't know, pointer's gone, sorry. This is sort of gas, so the darker things are gas-filled, so your lungs and the stomach is here. When you can see that there's gas that's gone down into the bowel, you know that you've got one of these phenomena. If you have the tube coiled, and we call this a kind of gasless abdomen, so there's no gas that's gone down, we know that there has to either be just a pure esophageal atresia and no connection whatsoever to the airway, or that they have a kind of upper pouch fistula. This one, which is rare, is much more associated with having a very long gap, and we might manage slightly differently postnatally. So they come up to Bristol in the ambulance. As has already been mentioned a few times, we look for the other anomalies, and those can have a big impact on the management of a child. From my point of view, what I want is an echo before I go in, and that's because, one, my anaesthetist wants to know how to manage the baby safely during the anaesthetic, but you can also get problems with the way that the main blood vessel in the body runs, so this thing called the aorta, and that runs very close to the esophagus anyway, and in some babies it lies, usually it's on your left side, sometimes it can lie on the right side, and that can make it very difficult for me to get to the esophagus and fix it. So at surgery in Bristol, we try and do what's called a bronchoscopy. And oscopy in medicine just means looking at something. So we try and look down the airway at the beginning. And so this is a classical picture that you'll see. So at the top of the image, this is the trachea. And this is the connection from the esophagus going to the trachea. So if you can see, this can be pretty big, and this can be why some babies get into real problems even before we get to surgery, because so much of the air that they're taking is just going straight down into their stomach rather than into their lungs. And then this is a kind of textbook, and I feel very happy if I open up and I can see everything like this. Generally what tends to happen, so we've kind of gone through the right side of the chest. The front, you've got the trachea, which has kind of got a muscular bit at the back. This is the top bit of the esophagus, and that's the lower bit that's joined onto the back of trachea. It's very, very uncommon that you open up and can see both ends. Generally, this upper pouch is usually sitting way off the picture, and you have to spend part of the surgery looking for it. And sometimes this can be much lower down and quite tricky to identify. But the principle is that you take this connection so that you get rid of all of the air flooding down into the abdomen, and you allow the baby's ventilation to improve. And it can be quite a hairy operation because these are tiny, brand new babies. I have to squash the lung to be able to see what I'm doing. And it's not that uncommon that babies with esophageal atresia are born prematurely. So it's a real collaborative working with the anaesthetist where I will kind of push, get the vision. They'll say, I can give you 5 minutes, but then you're going to have to let the lung come up again because I can't get enough oxygen into this baby. And that can be really difficult. But hopefully you manage to disconnect, and then actually you can pause. The baby's much more stable. But then there is a decision. So if you've had a really difficult time with the anaesthetist struggling to ventilate, then the getting rid of this connection and taking the esophagus off the trachea is the most important thing. So occasionally what will happen is the anaesthetist will say, I'm really, really struggling with the chest open and with you pressing on the lung. I can't look after this baby safely. And that's why sometimes we will just do what's called a ligation of the fistula. And then generally we'll form what's called a gastrostomy, so a little tube into the stomach so that we can feed the baby, and we'll come back when they're bigger and stronger and able to tolerate the surgery. The slide before I talked, when you have a pure esophageal atresia and you have this thing called a long gap, where the two ends of the esophagus, generally you define it as being more than 4 vertebral bodies away, that's a much more difficult thing to treat, and those babies are in hospital for much, much longer. And what we tend to do is try and give a way of feeding into their stomach and then wait 2 or 3 months and then reassess to see where we are in terms of, sometimes you can get a little bit of growth in the distal esophagus. And then we need to talk to families about what are we going to do if we cannot get the ends together when we go back in again. In Bristol, and it's a choice. So there's different expertise around the country. So Great Ormond Street in the 80s pioneered doing gastric pull-ups for children with esophageal atresia. And that is a good operation, and I've done that as a trainee. In Bristol, my colleagues who have now both retired, who are 2 formidable female surgeons, actually driven by a parent, said, a parent came to Miss McNally and said, I don't want my child to have a gastric pull-up. I've read about it. It doesn't sound great. I've seen that there's this person in Holland doing a jejunal interposition. Can you find out about it? And Miss McNally took that on board and invited the surgeon from Holland to come to Bristol and learnt how to do the surgical jejunal interposition, which essentially is taking a bit, the jejunum is just another word for small bowel. It's taking a little bit of your small bowel and kind of bringing it up into the chest and bridging that gap. And the advantages are the small bowel's the same size as the esophagus, and when it works, it can work really, really nicely. And your stomach produces acid all the time. So having your stomach up nearly at the back of your mouth, you get acid breath continually all the time. It's a huge, big operation with lots of problems. We always do it's a 2-consultant operation. The one that we did in January, 4 of us were in the operating theatre at various points during the day. And that's one of the absolute pleasures about being based and working in Bristol, is that my colleagues are all fantastic and we all work really closely together. So that's good. In Bristol, all patients have something called a TAT tube put down. TAT tube is the same as a nasogastric tube. Surgeons love to call it something different so that people magically treat it differently for a nasogastric tube. Essentially, we put it through where we've done the join, and that, if we're thinking that everything's gone really well, allows us to feed the baby sooner. We tend to always leave a chest drain as a kind of early warning system, that if this join isn't healing well, then we can detect saliva or other things coming out of the drain. That's not done in all centres. There are lots of centres where they don't put chest drains. The TAT is controversial. There's data coming out of the States saying potentially it increases the risk of strictures. In Bristol, all babies get a contrast swallow, which is where we get them to the X-ray department and ask them to swallow, and we check and make sure that the join is looking good. Again, not all centres do that. So if you've had surgery at other centres, they might not do that. And then once we're happy that everything's joined, then we start introducing oral feeds. I've got Helen, one of my colleagues here, who's one of our speech and language therapists, who's going to talk next. I'm not going to try and steal her thunder. But when we look at, that's a kind of straightforward course. There are things as a surgeon, every time I do a consent form, there's stuff that I go home and worry about after the surgery. And the most worrying thing that is a leak. And if you pick it up early, then you may have to go back in and fix it. Once baby goes home, you can still have problems with the stricture formation. And part of the surgical pearl study is we don't really understand why some babies get strictures and others don't. Some of it may well just be how far apart the ends were, but that doesn't always seem to be the case. So potentially a surgical pearl study could help unravel some of that. getting home. So I had a look at our last 5 years, and the shortest length of stay on our neonatal unit was 12 days, and some of that was before the surgery. And so that baby got home 8 days after their surgery, which sounds quite quick, really, but we want to make sure that they're feeding really well before you go home, and that you're happy that they're coping. And if you want to breastfeed, make sure that you're kind of managing to breastfeed well. When I looked at kind of overall, the median length of stay for kind of a relatively straightforward thing was about 3 weeks. However, we've got a little boy that's been in for about 6 months. He was born very prematurely. He's had lots of other issues going on. And so there's a huge spectrum of what can happen for families. And I always say to families, it's so stressful going through that process. And we do have psychologists that work on NICU, but I think sometimes I see patients back in clinic and they like, I didn't realise the impact that it was actually having on me until I've back to a normal family life without hospitals and interventions all the time. So the first year, I look after the range of VACTERL, so they're the kind of other end of the body as well, the anorectal malformations, and they're almost directly opposite in terms of how they do. So for esophageal atresia, the first year is often really, really difficult, and when you're in and out of hospital, seeing lots of people, having lots of appointments. The anorectal malformations, you kind of have your operation and you wait 3 years and we see whether you can potty train or not, but actually they then have many more issues going into childhood. Whereas hopefully for most esophageal atresias, in terms of having to be in and out of hospital, most of that's when the babies are really little and may not remember it, and then it tends to get better as they get older. So the thing that we kind of worry about and hopefully safety net appropriately is looking out for signs that your baby might be getting a stricture. And this is anything in your body heals, your body makes scar tissue. So if you cut yourself, you'll have a scar and your body will shrink that scar. When you've got a circular joint, then that will narrow a little bit. So the stricture rate for esophageal atresia is up at about 50%. And the signs of it that you've made you worry and we would want to see your baby is that the baby's taking a bit longer to feed. They might be pulling off the bottle or pulling off the breast, spluttering or choking, and in the worst case scenarios actually might be going blue, and then we definitely just want you to come up and see us. The other things, how's that gone? Are chest infections, and part of that goes to the fact that the trachea to begin with is a bit malasic, but also the fact that when you're one, you get lots of viral infections and it's the first time that you've been exposed to them. The other things we worry about are reflux. And then the most worrying are these things called acute life-threatening episodes where the child may stop breathing. And if you've got very severe tracheomalacia or you've had a reflex episode that you've aspirated, then that can be incredibly scary for the family and needs an ambulance to be called. I know I've said it was a whistle-stop tour and I'm aware we've only got a couple more minutes. So these are kind of pictures of, it's a bit bright in here to see them properly, but on the left side, there's a kind of narrowing the esophagus. We tend to use balloon dilators. And then this is the esophagus. I think this child just had 2 dilatations, and then actually the kind of join and the kind of healing process is stabilised and they're doing fine, haven't needed any more. For the recurrent chest infections, we work really closely with our respiratory colleagues in ENT. We have a very low threshold for having another look. Although we do bronchoscopy for babies at the beginning, it's quite easy to miss upper pouch fistula. So we'll have a high suspicion look for that, or a recurrent fistula. We're also able to do something called a 4D. And the 4th dimension is time. So you look at a baby's breathing while you're scanning their chest, and that gives you a really good look at the anatomy of the airways. I can talk and answer all sorts of questions about reflux. I'm just aware that I probably don't have very much time, but my take is that all babies get reflux. Esophageal atresia, you're much more likely to have kind of symptomatic reflux with vomiting and struggling with taking bigger volumes of feeds. And we kind of have a stepwise approach to trying to help that. At the very end, I might need to get back involved again with kind of either feeding beyond the stomach or something called a fundoplication, which I know there's information on the TOFS website about. And then the thing that I mentioned briefly, the very scary things, if this does happen, you will get readmitted into hospital until we've worked out what caused it and what we need to do to make sure it doesn't happen again. But that can be something that I know would be very scary for families to go through. Traditionally, the follow-up in Bristol has been completely surgical. This year, we've managed to set up the first specialist TOFS clinic that at the moment has just got respiratory involved. Part of the issue is geography. So actually asking people to come 3.5 hours up the motorway from Truro if they're doing okay for a particular clinic. A lot of families will do that. There are families who don't have the resources to commit to doing that. So we try and work flexibly. We do peripheral clinics down in those hospitals. Generally, it's much more intensive in the first 5 years. The older children that I'm now following up, a lot of them are on video appointments. I know we've got to talk about transition, but around the time of transition, I've got 14-year-olds who don't feel any different from anybody else and don't know why they've been dragged along to this appointment. Have to sit, it's quite interesting. You're like, okay, great, good. But we do try and educate them about kind of what's happened to them, small babies. In Bristol, we're unusual that we offer routine surveillance endoscopy every 5 years through childhood, which I can answer questions about as well. And then just to say, I know that TOFS has been supporting the setup of the TOAST trial. We are going to be a centre. Briefly mentioned surgical pearl, and then I know we've got to talk about transition as well, which is a work that one of my colleagues, Mr. Rogers, is taking on for Bristol. Sorry, that was a whistle-stop tour, and I still have gone over time, so I apologise, but very happy for any questions.